Um, and welcome to everyone as we talk a little bit about how I approach bone tumors today. This has been a lifelong love of mine, and I hope that as you understand and appreciate these lesions more, it will become enjoyable rather than painful for you as well. So there are a couple of things to think about with regard to bone cases, and some of the reasons why our initial reaction may be revulsion rather than welcoming them. First of all, they're relatively uncommon. They're hard to dissect. We don't have a lot of things. And then even under the microscope, there are a lot of things that kind of look alike and can be confusing. Additionally, clinical features are critical in terms of interpretation. And, we often don't get those. We may know the age and so forth, but we don't get all of the clinical details that we need. And then finally, surgery is often radical, and treatment can be fairly drastic and life-changing. So we don't like to make mistakes in this area. There's not a lot of room for error. But on the other hand, there are some things that facilitate the study of bone pathology and bone lesions, and that's something to be grateful for. First of all, the radiologists help us greatly by providing a lot of the gross features. And with the various modalities that we have, these are often very helpful in discriminating between different types of lesions, their contents, and so forth. And these provide kind of the grossing disease map that help us to know where to section, what to look for, and so forth. And they're also very helpful to provide correlations in terms of other sites and so forth. So that's something that's very helpful. As I approach these lesions, I think it's imperative that if you're thinking of a neoplastic lesion, you really should not sign it out if you have any potential to access the pertinent gross features as available on the radiographs, because that's really the standard of care. Is it's expected that you will correlate those, and that enormously helpful in terms of evaluation. Additionally, as you correlate the findings, that enables you to be sure or more confident that you're in the right differential, that you're thinking in the right terms, and so forth for a particular lesion. And when you get discrepancies, that's where you need to ask more questions, get more history, those sorts of things to make sure that things are going to fit together. Additionally, as we think about the different kinds of modalities that are available to us, it's important to remember that there are different advantages and disadvantages. So, for example, plain films give you kind of a nice summative view that is kind of the baseline standard that people have worked with for decades. But obviously, tissue overlap can make things a little bit obscure and may miss certain key issues like soft tissue invasion and so forth. CT scanning gives you sharp localized anatomy, especially for mineralized tissues, but it sometimes can underestimate the aggressive nature of margins because it doesn't discriminate that in quite the same manner that other things do. MRI, of course, is another great adjunct to studying these things, and this is particularly helpful for soft tissue lesions where it gives you more gradation in terms of fluid content, fat, and those sorts of things. And this can be very helpful in searching for things like skip metastases. On the other hand, MRI doesn't show you much of any detail of what the cortex looks like, which is often a very critical and important key. Now, another feature to be aware of is obviously location. And this means that you need to recall to mind some of the basic anatomical terms for the morphology in the bone. And particularly with regard to long bones, we have a metaphysis, we have the epiphysis where the growth plate is, and then we have the diaphysis. So the metaphysis, of course, is just between the physes, and the epiphysis is at the end of the physes, so to speak. Now, additionally, flat bones have a different sort of morphology, a different histogenesis, and that can be important. And then finally, medullary and cortical spaces have somewhat different arrangement of the bone, and you should be able to distinguish histologically between medullary bone versus cortical bone. Going on and thinking of this additionally, we need to think about whether the lesion we're looking at is bone forming or blastic, osteoblastic, whether it's lytic, osteolytic, in other words, degrading or diminishing the amount of mineralization, whether it's expanding, how it treats the periosteum, and how it interacts with the joint spaces, and what sort of margin it may have with regard to other bone lesion or other parts of the bone in terms of normal bone. Is it permeative? Is it sort of a sclerotic pattern, and so forth? Those kind of differential things can be very critical in defining the nature of the lesion, and that's why it's so important to look at the bone and get a feel for that. So this is just a nice little schematic to illustrate what some of the different types of margins that you might see. One of these is a sclerotic margin. As you see here, there's a little bit of accentuation of mineralization around the lesion. A sharp margin, but not sclerotic, also usually a benign, slow-growing lesion. And then as it starts to get more ill-defined and hazy, that's when you start worrying about more aggressive behavior. Moth-eaten or permeative borders obviously imply more aggressive lesions, and you should look very carefully to identify these sorts of changes in your lesions. Now, in terms of how the lesion interacts with the periosteum, I'm sure you've all heard the term Codman's triangle, which refers to the mineralization that happens as the periosteum is elevated off the cortical bone, and you get sort of perpendicular bone that is laid down as new bone between the new level of periosteum and the old cortical bone. Sometimes this can be very useful in terms of defining a lesion that's invading or elevating the periosteum, that's expansile, potentially permeating it. But it also should be an area that's not biopsied, because if you can identify that Codman's triangle, you're usually going to get benign reactive bone in that location rather than the neoplastic lesion. And so if you're seeing that area in a biopsy, it either means they didn't biopsy the right area, or they were on their way through something to get to something deeper inside the bone. Now, we mentioned that location and age are very important. These very classical diagrams were first popularized, I think 50 years ago, when the Mayo Clinic was putting together their series of bone lesions and so forth. Chris Uni and various other pioneers in the field did a wonderful job of categorizing the age ranges at which certain lesions were identified. And as you can see here, by each individual bone and location, the type of lesions or the number of lesions seen at that particular location. So if you can find this kind of data, that this helps you somewhat if you're looking at a particular location to realize kind of what kind of the differential might include based on, is it small cell, is it a bone-forming lesion, is it something else, sort of thing. It also can help you to think twice if you're in a lesion in an area where you have a very low incidence of a particular lesion, and you're trying to make a home run diagnosis that has never previously been reported in that location. It's also important to remember the basic bone histology and development. As you know, the medullary bone and the cortical bone are composed of osteons that have a type of lamellar bone laid down. And this is laid down over time. And so the mature skeleton has had all of these laid down, but then they have all been reorganized so that everything you see will be lamellar bone. In a juvenile individual, the osteons will have well-organized lamellar bone, but there will be intervening areas where you see more primary bone that has been endochondrally ossified and so forth without this secondary lamellar bone reorganization. So that can be a helpful thing in terms of dating the age of a biopsy and so forth. And if sometimes that's important when you're looking at something that may have been mixed up with someone else and so forth. Additionally, remembering kind of how the normal bone develops, especially long bones. This is critical both in terms of blood supply and understanding things like bone infarcts and so forth, as well as kind of the staging that may be involved in terms of transgression of the epiphyseal plate and so forth. So I won't go into that. That's kind of basic histology. But we realize that flat bones don't develop from an endochondral type of ossification, but are more of a fibrous matrix derived bone with peripheral osteoblastic rimming around these trabeculae, and that helps to distinguish new woven bone pattern growth. So in terms of pathologic processes, of course, the primary one is bone forming, but we also see cartilage forming lesions. We see lesions that are derived from stromal elements, both fibroblastic as well as vascular and so forth. Those are less frequent. We see some that are sort of a mixed pattern. Epithelioid hemangioendothelioma sometimes, for example, have mixed vascular and stromal components. Then we may see things that are secondary or foreign to the marrow that are infiltrative. These can be both mass forming as well as non-mass forming. And then the marrow-derived things like plasmacytomas, lymphomas, and so forth have a somewhat different appearance. So we'll just sort of run through some examples of things and do some describing. So here's some sort of old CT type lesions. And as you can see here, we have in the distal femur a osteolytic process. It's rarefying the bone here. And then we see it's a destructive process because it's destroyed the cortex out here. And as we can see from the CT scan here, there's a little bit of hazy soft tissue. And even on the ancient angiogram here, there's a slight curve to the vessels indicating that there has been some soft tissue mass displacing the vessels slightly. So you get also the idea of a very vascularized tumor. Well, in fact, this is a telangiectatic osteosarcoma here, this with a bit of bone cement in here after the biopsy was performed. And you can see this very destructive and very hemorrhagic lesion that goes past the epiphysis into the epiphysis and involves the metaphysis as well. So here's another lesion. This is a specimen X-ray, which is something that can again be very useful technique with a larger resection to help you evaluate something. But I think you can see here we have a nice Codman's triangle, and then we have a heterogeneous osteoblastic process involving here the the proximal portion of the femur. We won't pay a lot of attention to the distal femur there, but that corresponds to what was seen here, where you see this very dense osteoblastic process going on with obviously a soft tissue mass and destruction of the cortex. And then we see how these can extend proximally. So you want to make sure when you're evaluating these that you get a good view of that as well. Here's an interesting lesion. The history on this was quite fascinating. The guy says, "Oh, I got hit by a baseball bat, and then this lump arose." Whether that's the true history or not, at any rate, you can see that this is a lesion which is primarily adjacent to the cortex. It's right up and against it, but focally permeates into the cortex, through the cortex and into the medullary space, as you can see here. So while this may be a juxtacortical or perosteal osteosarcoma or some sort of thing like that, it's obviously developing a intramedullary component as well. Now here's an interesting lesion, a nice plain film, the old Panorex type of film with, as you can see, again, a lytic process, osteolytic process involving several bones in this situation. And here we have a little bit of cortical thinning and maybe destruction even in this lesion. So the fact that you have multiple bones involved here raises an entirely different differential for the lesion like this. The fact that it's lytic, again, it's destroying the bone, replacing the bone. And I think if we had a little bit of a magnifying glass, you might even see a little bit of the sort of features of sort of ring-like slight calcifications. We can also see that this is an adolescent patient, so it's a youthful patient, hasn't yet fused their epiphyses here. And this lesion is primarily in the metaphysis or diaphysis of these bones in the hand, not in the epiphysis. Well, how about this lesion? How would we describe this lesion? Well, it's obviously got a fairly sharp margin, at least in some areas. It's somewhat expansile, it's lytic, but it's not a great behaving with an aggressive type of margin. And so this type of a lesion might fit into something like fibrous dysplasia or something that has a slower growth phase and allows the bone to be remodeled and readjust to the expanding lesion inside. Well, this is just a nice histologic example of the way that endochondral ossification occurs here, where you can see this occurring. But this is obviously happening in an abnormal location. This is happening along the subperiosteal surface on a fairly long array of bony trabeculae here. So not in the usual way of an epiphysis, but you're getting endochondral ossification. So you could probably guess the sort of name for this lesion is an osteochondroma type of lesion that typically grows outward from a subperiosteal endochondrial pattern ossification. This is a little bit unusual in that it's over a fairly broad range of an area in the bone. Okay, so what about this lesion? We showed you this image before, and obviously this is from the pelvic bones. You can see here the joint is respected by this lesion, but it's making bone, but it does not have a sharp border. So it's osteoblastic, somewhat fuzzy, non-sclerotic border. This may be in the more potentially aggressive type lesion, either potentially an osteoblastic metastasis or a primary osteoblastic lesion like osteoblastoma, or potentially even osteosarcoma. So those would be things you might think about when you start thinking about osteoblastis. And here's an example of what the histology might look like for that, where you get nice osteoid formation, very cellular, some admixed giant cells. But we're not seeing a high degree of anaplasia here. We're not seeing a lot of atypical cells. And we'll get to those criteria, and you'll see more of these when you hear Dr. Tran's lecture later in the month. Here's another example, going back to that earlier fibrous dysplasia lesion. You see the nice curvilinear bone formation without a lot of osteoblastic rimming. So it's forming out of a woven bone type of a pattern. And although this is not a Chinese letter that Dr. Fung or any of the other of our colleagues could recognize. Well, what about this lesion? Here's another example of how to look at these sorts of lesions. This is obviously affecting the cortex, but I think you'd have a hard time defining where it starts and where it stops. There's really kind of very ill-defined nature to a border like this. So this is a nice radiographic example of sort of the permeative type of pattern of margin with a bit of cortical sclerosis and so forth going on here. Some elevation of the periosteum, I think you can appreciate here as well. There's some reduplication of shadows in areas like this. So this would be, a nice pattern for osteomyelitis or for Ewing sarcoma or a diffuse sclerosing variant, or a permeative small cell osteosarcoma type of pattern in a lesion like this. Here we'll change modalities, and here you can see some of the value in in MRI scanning in terms of being able to evaluate these margins. And you can see there's quite a bit of variability to that margin. And you can see here how the lesion has transgressed the cortex, because you begin to see a different type of tissue density here than what you would see with normal cortical bone. So this might define the extent of the lesion, but you've also got extension here into the adjacent tissues. And it's nice that you have the contrasting side for comparison. Here's another example of an osteoblastic lesion, but this is sort of almost sort of polypoid type of pattern. And you see there may be multiples of these sorts of lesions. And it looks as though it has some connection to the underlying bone. And here is where we see some of the challenges with plain films, because we can't localize whether this density here is inside the bone or opposite on the back side of the bone as a related entity to this. So it's difficult to know if this is an intramedullary component or otherwise. And even as many times as we rotate the patient and try to get lateral or angular views, we may not always be able to define that. Additionally, we see there's some abnormality here along the cortex extending. So you've got the possibility that you've got an osteoblastic and cortically destructive or expanding type of lesion here as well. So this is a very complex type of pattern with a lot of areas of expansion. Well, this is an unusual lesion. I'll talk about this just a little bit later, but this is an example of a lesion that is multi-osteal, or multiple bones are involved. And so this would be unlikely to be a primary single bone lesion, because you've got lots of hyperdense osteoblastic tissue, but it's well defined. It's very sharply defined. Even these up here are very sharply defined, and involving multiple bones. This is something where you might be thinking about some sort of a syndrome, or potentially miliary infection or something of that sort that could produce osteoblastic disease. This far distal, it would be less likely to be metastatic disease. So again, you'd probably be thinking of some syndromic or other sort of thing as a consequence of that image. Now, this is a nice little example of a localized area with sort of hazy margins. And yet on the CT scan here, we can see there's this little tiny lucency here. This is, I believe you can still see some open epiphyses here. So it's an adolescent. And there's this little lucent area here on the scan. Even though you don't see it very well here, in the setting of a history of bone pain relieved by nonsteroidals, this would be virtually pathognomonic of an osteoid osteoma. Contrast that with this in an older patient. You see this is the pattern of sort of moth-eaten margins. Here's some bites out of the cortex here, more up here. More destruction up here, and extensive up here. This would be a nice example of metastatic disease, showing you that moth-eaten pattern. All right, well, the next portion of this lecture, let's take a little bit of a turn towards some non-neoplastic bone lesions that may not be covered very extensively in our more neoplastic-oriented lectures later in the month. So this is just an example of a severe degenerative disease. As you can see here, there's fractures and some pseudo synovial type tissue here in this portion of the bone as well. So first of all, let's think about osteomyelitis. This is one of the more common lesions that will show in your experience, either in younger patients where it's a sort of primary disease, or sometimes as a secondary phenomenon in older patients as well. So things to think about in this setting are the fact that this is often bacterial, and in the younger patients, it's usually acute osteomyelitis. In older patients, you may be more inclined to see chronic osteomyelitis, and that has some characteristic features. There are rare parasitic cases. Echinococcal disease comes to mind, and then also fungal disease as well. And then, of course, we do want to never forget that tuberculosis can involve the bones as well. And sexually transmitted diseases, likewise, much less common in our time, fortunately, secondary to antibiotics, but there may still be cases where you could encounter this. Xanthogranulomatous osteomyelitis is kind of just a descriptive term where we don't have an identifiable microorganism. Have this very characteristic process that develops. So we'll go on here to the next slide here. So some of the times you may have acute osteomyelitis secondary to direct extension. So here you see the spinal process here. And I don't know why I'm getting so many phone calls, but I had none this morning, and I've had probably 10 here while we've been lecturing. So I don't know exactly what's going on there, but somebody, I should have had alerted them to take my phone. Anyway, you can see that you get a mixture of lysis as well as osteoblastic phenomenon here in this secondary involvement here from nodes adjacent to that. For osteomyelitis, we like to see bony necrosis and destruction, and then, of course, the associated fibrin, inflammatory cells, and so forth. You may be able to demonstrate organisms with specific stains, but it's a little bit difficult, as we know, to precisely define those with bug stains, particularly after you've had to decalcify a specimen. Chronic osteomyelitis has a very different appearance, and that's usually associated with a setting where you have incomplete debridement or treatment. This may lead you either to a Brody abscess, which is sort of a walled-off abscess, which can be a mixture of some acute and some chronic, or just a more reactive bone with maybe a minimal amount of necrosis and sort of a fibrotic marrow appearance with some plasmacytic infiltrate, variable amounts of that. So this can be somewhat challenging if you're not thinking of this in the right setting. So here's an example of what a Brody abscess looks like. And you can see it's got this lytic component as well as a slightly sclerotic and hazy margin. So it doesn't look really infiltrative per se, but it does have that very reactive appearance. And as you can see, this is a fairly young patient who still has the epiphyses intact. There is a syndrome called chronic recurrent multifocal osteomyelitis, which is fairly rare, but tends to produce sterile cultures. And these patients may have skin symptoms, multiple bones involved. There is a genetic component to this, and usually these patients do fairly well, but histologically, they tend to look more like a chronic osteomyelitis, so with the plasmacytic, slightly fibrotic appearance. So just to be aware of that syndrome. Now, aseptic bone necrosis, this is usually related to a number of factors, which you no doubt studied in medical school. This tends to be more common than we recognize. A number of bones can be involved, but we most frequently see it, obviously, in the femoral head, where the vasculature is particularly sensitive to this. But a number of possible etiologies, fractures, dislocations, steroids, vasculitic changes, various other sorts of things could all lead to this sort of a pattern. And grossly, it has this sort of marginated area of necrosis that will be in the epiphysis, poor vasculature, and then you may have a little bit of hyperemia around the periphery of it. In terms of evaluating fractures, which you don't necessarily have to do very frequently, but sometimes they can masquerade or be submitted as potential lesions. It's important to recognize that the nature of the reaction that you will see depends a great degree on the type of fracture, how long it's been there, what the underlying cause was, and the patient's age and how robust their healing response is going to be. So here's a nice time-lapse experience where you have the acute fracture, you fix it using the external fixators, you get things nicely aligned, you begin to get some repair, it heals in, and then ultimately you end up with a callus, so to speak, to give you that appearance. Under the microscope, initially you're going to see just a lot of fibrin, vasculature, hemorrhage, and so forth. And then as we go into the weeks stage, you'll begin to get this woven bone kind of pattern that then will begin to secondarily, form lamellar bone and get some reorganization and more firm fibrosis as you get into the later stages of healing for this lesion. Now, radiologically, they're usually sensitive to when something's a pathologic versus a physiologic or traumatic fracture. But we can see here that these two hips don't look quite the same. And we might see that there's a little bit of rarefication here, so we might be suspicious that something's going on. Actually, the CT scan was more helpful in defining the fact that we had a number of things going on in this situation, and that could include metastatic disease, as you can see here, sort of infiltrating the marrow and creating a weakened bony structure that was then susceptible to fracture. In contrast to the more normal fatty marrow that we see up here in the epiphysis and the subarticular surfaces. Now, one of the problems that sometimes besets us with fractures is evaluating the pathologic healing process where there is non-union. And essentially in this situation, you're forming a secondary pseudarthrosis in this sort of a situation. So what do we mean by that? What is associated with non-union? Well, there are several common sites where this can happen, particularly in the spine or in the scaphoid bones in the hand. But any displaced fracture that isn't properly aligned and allowed to heal, where there's maybe interruption of the blood supply or incomplete vascularization of that, can lead you to that sort of a problem. And you get a very delayed and poor callus formation in these settings due to the poor vasculature, and potentially even then the secondary pseudarthrosis or joint space that can be formed. Here again, clinical history can help you because otherwise you're looking at that tissue and you go, well, is this neoplastic cartilage and bone? Is there something else going on here? Is there infection or whatever? You can really be led down the garden path if you're not attuned into this. All right, well, let's talk about a number of benign reactive lesions, and this will include giant arachnoid granulations, hyperostosis cranii at vacuo, hyperparathyroidism, so-called brown tumors, bone infarcts, and then a number of metabolic disease. So here's a rather famous case from the Mass General. This ultimately presented as one of the old CPCs in the New England Journal, where a patient presented with a lytic skull lesion. Had a normal serum protein electrophoresis, but this looked radiologically for all the world like lytic bone disease related to multiple myeloma or similar disease, and ultimately came to resection. And on resection, it was found that these, in fact, were just giant arachnoid granulations that had indented the calvarium and produce this lytic appearance. One of the variants of normal. Hyperostosis cranii at vacuo. We don't know all the etiologies for this lesion, but it leads to this marked frontal hyperostosis. Certainly, if you do enough autopsies, you'll see this more than once in your career, and it's typically not a pathologic process to be worried about. Now, hyperparathyroidism can lead to the formation of these little islands of fibrotic tissue with a mixture of giant cells, maybe some fat cells and spindle-shaped cells that might look like a giant cell tumor or whatever, but they tend to be in a non-giant cell tumor location. And so this is, again, why it's very important to correlate the radiograph with the histology. So seeing this in a diaphyseal location, having this histology, you're going to say, what's the calcium? What's the PTH? Does this patient have hyperparathyroidism? Rather than saying, oh no, this is a giant cell tumor of bone, or even worse, something more aggressive. All right, bone infarcts, we've talked about these. So say this 5 times fast before you go to bed every night, and your tongue will get its workout. Diaphyseal metaphyseal infarction. Infection, vasculitis, sickle cell disease, pheochromocytoma, other vascular disease, Gaucher's disease. This is a long differential. We've talked about the aseptic necrosis. Well, this is essentially what we're talking about, that. But if it's just the epiphyseal type, that's a little bit different, this differential as well. So I don't expect you to remember all of these, and they probably won't all be on the boards, but I would expect that this is sufficiently frequent enough that you might get a case of this sort where there's a slight differential between these two. For example, pheochromocytoma is usually not a etiology for the more epiphyseal type of bone infarct. If you just get a pure medullary infarct, these are more likely related to some sort of embolic disease or something of that sort, because just of the location and so forth. And then subchondral infarcts, these can be wedge-shaped and so forth, whereas the cartilage will remain viable because that's provided nutrition by the synovial fluid. So just sort of characterizing the different locations where you might see those. So what might one of these look like? Well, here's an example, sort of an osteoblastic process, not particularly aggressive looking margins, not well defined. This is, in fact, osteoradionecrosis, and this is usually defined within a couple of years of primary therapy, and leads to bony necrosis or empty lacunae, and a secondary marrow fibrosis with variable cement lines, neovascularization, hypercalcification, and so forth. And this can sometimes be fairly subtle to find. So sort of like that previous radiograph. Gaucher's disease, we don't see this a whole lot, but in certain populations, certain settings, you might see this more frequently. These cells like to accumulate in the marrow of the bone and can give you a variable lytic pattern. It can be subchondral, it can be multifocal, multi-osteal, and you can end up with a variety of deformities. This is the so-called Erlenmeyer-Flask deformity. Not that very many people nowadays would know what an Erlenmeyer-Flask looks like. And you get this very infiltrated pattern in the marrow, where you can see there's a change in the marrow characteristic here, up here as well. Well, there are other metabolic bone diseases which can present with differing patterns of ossification. And these are listed here: osteopetrosis, marble bone disease, osteopoikilosis, osteoporosis, very common, Paget's disease of bone, renal osteodystrophy, rickets, and so forth. Here is the image that we saw earlier, which is in fact an example of osteopoikilosis. And this is a disorder that presents with multiple hyperdense bone islands, usually around a joint. And these are sometimes associated with the Buschke-Ollendorff syndrome, which is a heritable, I think, autosomal dominant disorder that is fairly uncommon, but has this very unique radiographic appearance. Now, Paget's disease of bone has sometimes been called matrix madness. And you'll see here in this polarized light photomicrograph, the normal lamellar bone here around an isoversion canal. But you can see the intervening bone is just sort of this bizarre, multiple different layers, different directions of this bony matrix that has been laid down, remodeled, and so forth, indicating that it's just not organized in the usual sense of the way that the bone should appear. And it also appears to increase in mass. So there are several phases of this disease that can be both lytic or osteoclastic or blastic or mixed in various ways. And so that also goes along with this sort of matrix madness notion. Most of these patients have more than one bone involved, and there are occasionally some associated neoplasms. I've seen one case in my lifetime of post-Paget's disease sarcoma, and have not seen a giant cell tumor. Here's kind of another example here of how this looks. Here you see these irregular ossification lines here, and the mixed pattern of blastic and lytic and destructive disease here. All right, well, let's take the last few minutes and talk about some of the benign fibroosseous lesions that you may encounter and that may not be covered in some of the other lectures. These tend to be fairly common, and so you do need to be familiar with them. But very often the radiologists are quite adept at identifying these. So this includes fibrous dysplasia and fibroosseous dysplasia, slightly different disorders, metaphyseal fibrous defect, myositis ossificans, ossifying fibroma, fracture callus, particularly secondary stress fractures, and liposclerosing myxofibrous tumor, which we'll talk a little bit about. So fibrous dysplasia, you're aware of this disease. We've mentioned it briefly already, showing you one example. Here's another. This variably complex lytic and slightly sclerotic lesion. This is an intramedullary process. So it tends to have this osteolytic center because these don't completely mineralize in quite the same way as the other bone, but it has this sclerotic rim. It can change the architecture of the bone, giving you cortical expansion. And what we see in this is entirely woven bone. So no rim of osteoblasts. And the cells are very bland spindle cells. You see the ossification is sort of more characteristic of woven type bone without the nice lamellar zones of ossification lines. Now, in contrast, fibroosseous dysplasias, no, that's the next one. A fibrous dysplasia has both single bone and multiple bone forms. It's usually just one side, and it tends to affect both long bones and flat bones, including some of the craniofacial bones. It does have some associations, particularly the polyostotic forms with McCune-Albright syndrome, some forms of hyperparathyroidism, and so forth. But it's usually a young adult, late adolescent kind of presentation for this disorder. Now, osteofibrous dysplasia is somewhat similar histologically, but this is cortical only. There's no medullary component, and this does have osteoblastic rimming. Now, interestingly, some of the spindle cells within this lesion can be cytokeratin positive, which is sort of an interesting finding. So here's kind of what this would look like: sclerotic margin, lytic center, and here you see this nice osteoblastic rimming in this lesion. This is also sometimes called fibrous cortical defect, but I think this is more characteristically osteofibrous dysplasia, a better term. Now, what is a metaphyseal fibrous defect? Well, this is also called fibrous cortical defect or non-ossifying fibroma, fibroxanthoma, fibrous histiocytoma. All of these communicate a benign entity that is not going to require radical surgery and may respond to just very local therapy. Some of these actually will resolve spontaneously, so sometimes you get them in different phases. Now, this is typically a long bone in the metaphysis, and it may extend a little bit up into the diaphysis if it's been there for a longer period of time. So here's a radiographic example showing the lytic component of this, sclerotic margin, and a slight extension up here towards the diaphysis. Here we see what this looks like histologically, very bland cytology, no ossification, occasionally some foamy histiocytes and rare giant cells to this lesion. And here again, you see how this could be confused with, fibroosseous dysplasia here in the cortex, sort of a pattern, but in this location, we're thinking of this entity. Okay, so just a few more things to cover here. Ossifying fibroma. This is characteristically seen more in the oral pathology practice, but occasionally these lesions will come to a general surgical pathology bench. And this lesion is related to these other lesions, but sometimes it's called sort of the ossifying cementoma, because you can see it sort of has this cementum type of a pattern here. And again, we see no particular osteoblastic rimming to this disease. It's coming out of a more woven pattern. It's just that the little entities here tend to be a little bit more rounded type of a pattern. Now, the differential here, of course, would be things like osteosarcoma, but the cytology, the very low-grade appearance, and the radiographic sharp margins and so forth should alert you to the more benign lesion. Myositis ossificans is a bone-forming lesion occurring in soft tissues. We know that it does have some traumatic background, but it also has a genetic component, or at least a mutational component, related to other similar lesions like I'm blocking on it here. Senior moment here. Nodular fasciitis and so forth. But this can oftentimes be confused with malignancy. These classically have what's called a zonal pattern of ossification, where the more mature ossification is peripheral and the central zone is less mineralized and less ossified. So it seems to be growing from the center out and maturing from the center towards the periphery. As I mentioned, it does have some relationship to nodular fasciitis, particularly in the proliferative zone. And what determines which lesions ossify, which lesions don't, I'm not sure I know at this point. There may be some of you might know that in your studies. So here's just a nice radiographic example. And this, I said this matures from the inside out, So you may ask, why doesn't the periphery here look more ossified than the center? And I don't know the answer to that question, unless it is we're just seeing that it's that we're seeing the proximal and deeper outer portions more easily through this central portion, and you can see that there's still sort of this sharp margin here. So the bone again tends to be woven type of bone that is fairly benign and bland appearing, with a slightly cellular spindle-shaped stroma producing it. Okay, liposclerosing myxofibrous tumor. So this is an entity that was has an interesting history, and Dr. Deal, when she was a resident, wrote up a case of this with me to review. The name of this was back in the days when they wanted to have very memorable acronyms, and one of the authors on that particular study, I believe Bruce Ragsdale, who was a somewhat infamous resident ahead of me at Mass General, wanted to give it a name that was very memorable, and wanted an acronym that was gonna catch the eye. Well, he was a smoker, and as it turned out at that time, there was a particular brand of cigarette that had the initials for their tagline of LSMFT. So he wanted something that could use that acronym, and he came up with this term, liposclerosing myxofibrous tumor, or LSMFT, as kind of his tribute to the literature and the desirability of nice acronyms. Well, anyway, however that is, this is a very unusual looking lesion that has elements of lipoma, fibroxanthoma, myxoma, myxofibroma, cystic lesions, fat necrosis, ischemic ossification, and fibrodysplasia-like elements. This can occur in just about any age group, but the location is almost uniformly proximal femur. There are a few other cases in other locations, and some of the initial studies thought that there might be a malignant transformation. I think most people doubt this, and there's really a lot of some genetic indication that this is related to fibrous dysplasia, because it tends to have a similar mutation. And that's kind of the story on this lesion that we'll stand by at this point. The demonstration of that is a little bit challenging, and not every patient gets followed up with that regard. But at any rate, if you see a sort of complex lesion in one of these locations, this is most likely going to be the diagnosis, especially if they have any other indications of fibrous dysplasia. So I'm going to stop there because my next slide says osteosarcoma, and open it up for questions for any of you that want to ask any questions.
For the myositis ossificans, I've seen an entity where they've noted, myositis ossificans circumscripta or something of that nature. Do you classify it any further than just the myositis ossificans?
I don't think you need to. I mean, circumscripta obviously just means it's very circumscribed, defined, sharp margin sorts of lesions. I suppose there are different types of injuries, more like crush injuries or something of that sort, that might give you a more diffuse pattern of myoossification, but I wouldn't bend over backwards on that distinction.
Okay, thank you.
Any other questions? All right, well, I appreciate the time to spend with you, and we'll post this video, make it available to you. And thank you, everybody, for participating.
Thank you.
Thank you.
Thank you.
Thank you.